Masud. Yeah, first of all, thank you so much for inviting me to the Enigma Sleep Talk series. It's really a pleasure and an honor to be here. And I'm going to talk about sleep, insomnia, and depression. And actually, there are two main messages I have. The first one is after my lecture, you should understand or get a feeling for why sleep is important for mental health, especially depression. And you should also understand, or at least get an opinion about why insomnia treatment could really be a preventive strategy for mental illness, especially depression. So these are the five topics I'm going to talk about. I will kick off with a brief history of psychiatric sleep research, of the view of psychiatry towards sleep. I talk about REM sleep and the function of REM sleep, the function of sleep in general. And then we switch to insomnia and the concept of hyperarousal. What is hyperarousal? What do we mean by it? I'll talk briefly then about a meta-analysis we performed on sleep in mental disorders. And then I'll end up with a chapter about what is the clinical relevance of all of this. Now, this is the rather sinister looking gentleman here is Emil Kraepelin. He was a famous German psychiatrist in the 19th and early 20th century. He is also thought to be one of the founder fathers of modern psychiatry and especially biological psychiatry. And he published a well-known textbook. And here I have the German text here, but I give you just a brief translation of this. And he was also working a lot with depressive patients and developing a nosology for depression. And he mentioned here that people with depression, they are very tired and they are very in need of sleep. They really want to sleep, but they are unable to find sleep. Sleep onset may be a problem, or also sleep maintenance. That is to say, there are frequent awakenings, and especially there might also be a very long early morning awakening accompanied by really the nadir of mood. Many depressed patients wake up and in the early morning hours, and that's the time when they feel most depressed. And some patients have even a kind of circadian rhythmicity of their mood. That is to say, they feel very depressed in the morning hours and spontaneously improve during the day and towards the afternoon hours. So the link between insomnia symptoms, sleep onset problems, sleep maintenance, early morning awakening, and depression was also known a long time before Kraepelin, or it's already mentioned in antique times. Now let's jump forward a bit from Kraepelin to 1969. This is a study from the US, and it looked at, I guess, around 1,500 hospitalized patients in a large US hospital. And they asked them just to note which kind of symptoms they have. And naturally, if you have the diagnosis of depression, you have depressed mood, that's 100%. But in this study, also 100% of patients complained of any kind of insomnia. And this is still a finding which holds true if nowadays there are modern studies in outpatients, in inpatients, and usually if you have a diagnosis of depression, at least some 70 to 80% also report some insomnia. Insomnia is also sometimes the earliest symptom. That's how it starts. And it's also can also be the most persisting symptoms. People may improve with the depression, but they may still suffer from insomnia. So there's a tight link. And the traditional psychiatric view was insomnia is a symptom of depression, and the assumption was also if you treat the depression anyway, the insomnia will improve by itself and it will go away. And you'll see during my talk that this view has changed in the last 50 years. There was an approach towards towards measuring sleep in depression in the sleep lab. And this started with, especially with the work of David Kupfer in Pittsburgh already in the 1960s. And they published some groundbreaking work. And this is just an example of this. You all, probably most of you, are aware of the typical cyclical sleep patterning in good sleepers that we have up here, and down here we have a depressed patient in an unmedicated state. And there are three hallmarks of depressed sleep in the sleep lab. First is the disturbance of sleep continuity. In that case, for example, an early morning awakening. Actually, in the early times of polysomnographic psychiatric sleep research, this was taken as this is unspecific, this is not specific for depression. This also occurs in other mental conditions. And so it's not interesting because we were looking for biological markers. Everybody was looking for biological markers. Then we have a reduction in slow wave sleep compared to good sleepers. But what really attracted the attention most was this early onset of REM sleep. In that case here, it's even a sleep onset REM period, like you also find in narcolepsy, which is a totally different condition. And this was called REM sleep dysregulation or disinhibition of REM sleep. Early onset of REM sleep, very long first REM period. Usually the first REM period is short, and increased amounts of eye movements. And it was thought to be a biological marker of the endogenous melancholic subtype. In the 70s and 80s, psychiatry is still looking for biological markers of its diagnostic subgroups. It was thought to be that this might even be a biological marker for the biological somatic endogenous depression. And what also supported this view was the very interesting finding, also already in the 1970s, that most antidepressants on the market, and this also applies to modern antidepressants nowadays, they do suppress REM sleep. That is to say, this imbalance or this early onset of REM sleep is corrected. So it seemed as if there was a biological marker, and is as if our working drugs, our potent drugs, were correcting this imbalance. So we were talking about even a window to the brain. And furthermore, what made the whole story even more interesting at that time was the fact that there was a nice animal model of non-REM-REM regulation. It was Alan Hobson, Bob McCarley, both of them pioneers in psychiatric sleep research, and they also worked in basic research in cats. And they were able to show that the dynamics of non-REM and REM sleep are regulated by the interplay between aminergic and cholinergic regions, neuronal centers in the brainstem. And they call this the reciprocal interaction model. And interestingly, it was shown that, for example, you can provoke an earlier onset of REM sleep just by cholinergic stimulation. They published something in Science where they kept a cat for 8 hours in REM sleep by constantly infusing cholinergic substances into the brainstem. And that's why they also suggested already 40 years ago that the early onset of REM sleep in depression may be due to an imbalance between cholinergic, aminergic neurotransmission. And that was also the prevailing thinking at that time, that depression has something to do with an aminergic deficiency on the side of noradrenaline or serotonin, and it brought into play the cholinergic system. So that was really very exciting at the time, having a biological marker which reacts to therapy and which has a good underlying animal model of REM sleep regulation. However, in the 90s, data were published, meta-analysis showing that the REM sleep findings, they are not so specific for depression, compared to other mental health, mental illnesses. And it also became clear that probably neuroimaging might be an easier way to gain access to brain activity and function than, running sleep laboratory studies. In order to do these studies in depression, people have to be off medication for a week or 2 weeks, and you need to have them for 2 or 3 nights in the sleep lab. On the other hand, if you do magnetic resonance imaging, you just need an hour in the scanner to gain access to, or to see at least to some extent what's happening in the brain. So that was taking away a lot of the momentum of psychiatric sleep research. But actually, at that time, I got really hooked with REM sleep. This is something which REM sleep still fascinates me. That's why I also have this paragraph here about REM sleep, the function of sleep. So, published 71 years ago, Azarinsky and Kleitman described the discovery of REM sleep, and I'm just going through some of the REM sleep phenomena now with you. I'm just showing you a brief film, and it kicks off with, it shows you what people nowadays do before they try to fall asleep, and then you see a brief episode with the eyes rolling under the lids. So this is not yet REM sleep. This is what happens before sleep in many people. They're watching their smartphone, yeah? But now we have, I think you clearly see the eye movements under the lids, and it's a fascinating state because it's accompanied frequently by dreaming. So this is now from an excerpt from a sleep recording. We have the rapid eye movements. We have a low voltage EEG in REM sleep. And if we think in terms of metabolism, brain metabolism, what's going on in REM sleep, and Masoud knows this probably much better than I do. This is from a study, a pioneering study by Pierre Mackay, first PET study in REM sleep in good sleepers. And he was able to show, this group was able to show that if we look at the pons, at the amygdala, the thalamus, and up to the cortex, in REM sleep, we see increased activity, metabolism, glucose metabolism in the areas which are in yellow here, compared to the wake state. So the REM sleep state, to some extent, is a more active brain state, or in terms of glucose metabolism, than is the wake state. And that was really also very important finding. And what we also have, and this is makes the whole story even more fascinating about REM sleep, is the fact that there is muscle atonia in REM sleep. So we can't move, we are like paralyzed. And that probably fulfills the function that we do not act out our dreams. If this were not the case, like it is in REM sleep behavior disorder, we would all start to move and kick around or even trash around and cry and shout and whatsoever. So the evolution has not only developed this strange sleep state, but also put a break into that nothing untoward happens during the night if we are in a brain state. There are many interesting theories about REM sleep. The one which is interesting from a psychiatric perspective is the hypothesis put forward by Matt Walker and associates. And he postulates that REM sleep is important for emotional brain function, for dealing with emotions. The interesting thing in REM sleep is the fact that the locus coeruleus is totally silent. Usually the locus coeruleus is active during the wake state and is also, we need it to be awake, but it's also necessary in order to deal with stress. It reacts to stress. And there is no activity of the locus coeruleus in REM sleep. And Matt Walker postulated that this serves to dissipate emotion during the REM sleep state. So in a way, REM sleep would serve the function to deal with emotions we had during the day before, and REM sleep would somehow neutralize these emotions. Now there's also some speculation inherent in that theory that can't be that needs to be acknowledged. It's a fascinating theory, and there are lots of data speaking or supporting this theory, but there are also data not supporting this theory so much. But it would nicely tie into the fact that depression, which is primarily a kind of emotional disequilibrium or emotional disturbance or disturbance of emotional regulation, somehow is accompanied by dysfunctional REM sleep. And you are well aware of many other functions of sleep per se, information processing, memory consolidation. These are data which were also published by the Bonn Group in Tübingen. And there is supposed to happen some kind of declarative memory consolidation during sleep, probably during non-REM sleep and slow wave sleep. And there is this interplay between the hippocampus and the cortical or neocortical structures serving probably memory consolidation. Others have suggested not conflicting theories, but alternative theories saying sleep per se serves synaptic homeostasis. This is the Gerelli and Tononi hypothesis. And most recently, from the Niedergard group in the US and Denmark, it was postulated based on animal data that sleep per se may have its restorative function as a consequence of the removal of potentially neurotoxic waste products, especially beta amyloid, that accumulate during the awake central nervous system. So sleep would be something like a garbage train or truck going through the brain and just sorting out all garbage, you know. So there is no doubt that sleep and REM sleep serve important function, and that has always been a driving factor for our group, that we really think that sleep in general is extremely important for brain and mental health. Maybe REM sleep more tied to emotional functioning, slow wave sleep tied to executive cognitive functioning, and there's circadian processes involved, homeostatic processes, and there is something like a hyperarousal in many sleep disturbances and in many mental disorders interfering with the normal or the adaptive function sleep usually has. So now let's switch to the topic of insomnia. DSM-5 brought up an overarching category of insomnia disorder. Before that, most diagnostic criteria were talking about primary and secondary insomnia, or organic and non-organic insomnia. And the basic assumption was that mainly insomnia is a symptom of somatic disorders, of mental disorders. There is a small group of, primary insomnia, but mainly it's a symptom. And the basic assumption was also, if you treat the primary disease or disorder, then the insomnia, as it is just a symptom, will disappear. And that it turned out that this is frequently not the case. So we have this new insomnia disorder category allowing to diagnose this more frequently, and not saying there is a hierarchy and you don't diagnose insomnia if there's an underlying disorder, but you can now also diagnose both an insomnia disorder if it's very pronounced and independent, and a comorbid somatic or mental illness or disorder. So that was an important step forward, and this is also reflected in the ICSD, the International Classification of Sleep Disorders, and this is also will also be reflected in ICD-11, which actually has already been published, but it's not active really. At least in Germany, we still use ICD-10. Now this is, if you look for insomnia disorder, this is quite frequent. This is something we put together for a guideline we published in 2017, and we only tried to use high quality epidemiological studies. And if you look at that, interestingly, Germany has quite a low rate of chronic insomnia, also England. Maybe that has changed after the Brexit. And France, for example, has a very high rate. In France, you find almost a fifth of the population suffering from chronic insomnia. And what happens in parallel to that is the fact that France is one of the countries having the highest prescription rates for sleeping pills compared to other European countries. So based on this and on other data we have from Germany, we would suggest that approximately something 6, 7, up to 10% of the European population, and probably also the population in at least other industrialized countries, suffer from chronic insomnia, meaning they have insomnia symptoms going on for at least 3 months and experiencing daytime consequences of their insomnia. And usually insomnia afflicts more women than men. The ratio is something like, let's say, 2/3 to 1/3, and insomnia increases with age. Now, it's to associate insomnia with hyperarousal has a long tradition. This is 150 years old, from a British author, and he talks about insomnia and he says, well, it can be upon degeneration of the cerebral arteries. This would be old age insomnia, difficult to cure. It can be toxic upon abuse of alcohol, tea, or tobacco, and it ceases upon the removal of the cause. This is sleep hygiene, as what we also use as sleep hygiene nowadays, that we think that stimulating substances, well, you should avoid them if you have insomnia. And in the psychical arena, it may arise from continued and excessive mental strain, grief, anxiety, worry. That would be the hyperarousal, the mental hyperarousal. And interestingly, it's usually successfully treated by full doses of bromides. We don't recommend bromides anymore because the threshold between therapeutic doses and lethal doses is very small. So there were many incidental overdosages and people who killed themselves. And what he says as well, if the insomnia is serious, it must be stopped at once by hypnotics. I would underwrite the stopped at once by hypnotics, but not what he writes here, preferably by opium. This is what you got 150 years ago. If you could afford it, if you had chronic insomnia, you would be treated with opium, with laudanum, and you would have a huge chance of developing two problems after a few weeks, namely have still the insomnia and having an addiction to opium. So that's not the way to treat the insomnia. There have been different models. I'm starting with the psychological ones and then leading you to the neurobiological assumptions. This is the model by Spielman about insomnia, a psychologist from New York, and he said, actually everybody once in a while has a few days of insomnia, or 1 day or 2 nights. So there must be something premorbidly wrong with those who develop chronic insomnia. And he speculated either about personality factors or about genetics. And there is now even molecular genetic evidence that there is involvement of genetic factors in insomnia. It doesn't explain the full variance. It may explain 30 to 40% of the variance. And then in order to develop short-term insomnia, you need to have precipitating factors, usually stressful events, too much work, conflicts in your partnership, etc., and you will have troubles falling asleep or maintaining sleep for a few days. Most of us can deal with that and will sleep good again if the stress goes away. And we have perpetuating factors, and that is probably Art Spielman's most important discovery, because he said it's behaviors of the afflicted people which maintain the insomnia. And he suggested that, or he had the impression that many people with insomnia, when they have insomnia for a few days, they tend to prolong their time in bed as a safety behavior in order to maintain the amount of sleep they think which is necessary. And he suggested that this is exactly a maintaining factor. If you have long bedtimes, not just 8 hours, but 9 hours, etc., elderly people have even 10 hours, and you wait for your sleep, this will somehow perpetuate the insomnia. Another psychological model comes from Charles Morin, a Canadian psychologist, and he suggested on the one hand an arousal, a hyperarousal, an interaction with dysfunctional cognitions. Most people with chronic insomnia start to worry over the sleep loss and ruminate about the consequences when in bed. They tend to develop maladaptive habits like long times in bed, irregular schedules, especially trying to catch up on weekends, napping during the day. And the consequences are like an impact on mood. I'm not saying depression at once, it's more irritability, it's dysphoria, concentration problems, fatigue, performance impairments. Just let me give you an expression what happens with people with insomnia. There is a nice documentary called Wide Awake by an American filmmaker, Alan Berliner, and he has chronic insomnia, and he made a film about it.
I can't take it anymore.
Do
Go
you
to
hear the
sleep.
sound? Yes.
Forget it. Think pleasant thoughts. Think pleasant thoughts. Inhale. Exhale. The baby's coming in 2 months. I've never changed a diaper in my life. Do I watch the birth or film the birth? Shooting it would be better for the film. But how can I watch the birth of my child through a lens? Just relax. I'm too tired to relax. I'm gonna be a zombie tomorrow. I feel like a zombie right now. What was I saying? What if he wants to be an economist like Shari? What if he becomes a doctor? That would be okay. He could get me the latest sleeping pills. Stop it, just relax. He's not even born yet. He's gotta go to nursery school first. That reminds me, we have to get the applications early. New York City nursery schools are really competitive.
Yeah. So I guess you get the message, and this is something probably everybody who has also in this room and listening to me has experienced once in a while, these endless ruminations, these loops of thoughts and worry which lead to nothing. And that's very typical of people with chronic insomnia. It's also very typical of people with depression, rumination and worry. And I just now give you an overview of the behavioral level. Just 8 hours in the sleep lab compressed down to 30 seconds of a good sleeper and a insomnia patient. And I don't need to tell you probably who is whom. And I guess I find this tossing and turning a very nice description where people say, I was tossing and turning the whole night. And if you just compress 8 hours to 30 seconds, you see it clearly that also on a behavioral level, there's much more activity here in our patient here with insomnia. There's also motor activity in good sleepers. We all turn around a few times, probably. That's good for us, but not as much here as in the patient with insomnia. We published a few years ago a first meta-analysis of polysomniac characteristics of primary insomnia, and all the variables here in red gave us a significant difference between insomnia and good sleepers. So there's more wake time, there's a little less REM time, a little less slow wave sleep, there are more awakenings. The sleep efficiency is decreased, there's a longer sleep latency in insomnia. Total sleep time is also decreased, but there's a big but here. It's the absolute difference between good sleepers and people with insomnia is 25 minutes. What we found in this meta-analysis. On a subjective level, if you use sleep diaries, the difference is like 2 hours on average between people claiming chronic insomnia and good sleepers. So there's a mismatch between what we can measure with polysomnography objectively and what patients experience subjectively. And that is a finding known for even also now for 50 years, and which has led to the fact that, well, many physicians, doctors, psychiatrists, etc., don't take insomnia so seriously. You know, think, okay, people might imagine that. The interesting, and that has this mismatch between the subjective and the objective level has led us to run many studies to find out what is this really about, what is wrong with sleeping insomnia. So this is again a good sleeper. This is a patient with insomnia, and what you can see here is on average, it's not really a massive loss of sleep the patient with insomnia experience, but sleep is much more fractioned or restless, and especially in REM sleep, we have a very high number of microarousals and just awakenings and microarousal. And if we look at the spectral analysis of the sleep EEG, in insomnia per se, what we find is increases in fast frequencies in the beta, sigma, and even in the gamma band. So superimposed on what looks like, well, not totally normal sleep, but only slightly deranged sleep, superimposed on that sleep, we have increases in fast frequencies. And we do think that this reflects more cognitive processing during the night, not only in non-REM sleep, but also especially in REM sleep. That is to say, people with insomnia don't experience their sleep or their more restless looking sleep. They don't experience this sleep as sleep or being unconscious, but they experience this as ongoing cognition augmentation. And we focused especially on REM sleep because we were able to show in a first study that there's a strongly increased amount of arousals in REM sleep compared to non-REM sleep. There's also an increased amount in non-REM sleep, but very strongly increased in REM sleep. So we suggested an idea of there's something like in REM sleep instability, and Us van Someren in Amsterdam called this restless REM sleep. We did a first study, and I'm showing you some data in insomnia patients in the sleep lab and good sleepers in 27 subjects each. And what we did is we woke them up from REM sleep, from 3 REM periods and from 3 non-REM sleep episodes. And we asked them, have you been awake? Have you been sleeping? Or are you unsure what state you were in? And interestingly, if you wake people up from non-REM 2, you find that also 20% of good sleepers indicate I was awake. Also like 25% of people with insomnia. But the huge difference was especially in REM sleep. So if you are in REM sleep and if you're a good sleeper, you will experience dreaming. And that gives you an anchor that you must have been sleeping because you're experiencing like some kind of visual hallucinatory experience. And interestingly, this was significantly less the case in insomnia. And people with insomnia were less secure in also during the awakenings to say, I was awake, I was not awake. You know, they were saying there's a much higher level of insecurity about that. So there is something with how sleep is perceived, which is different. Also, if you directly investigate that. And interestingly, if we looked at the emotional state over the awakenings, and here we have just the REM sleep awakenings, and if you look at negative emotions, good sleepers don't accumulate negative emotions. Even we woke them up, this is quite aversive, but they said, no, my mood is not altered. But people with insomnia showed an increasing amount of negative emotions over the course of the night, which would tie into our hypothesis that what they experience subjectively, cognitively, is not being able to sleep, which gives them a negative mood. And next study, we thought we would look at event-related potentials. And this has the advantage that that you not just wake up people, and you can't wake up people 20 times a night. You can do it 3 or 4 times, otherwise it gets very aversive. But we're playing tones to people, and this were like over 10,000 tones per night. And we did this in a baseline in 2 nights, and in good sleepers and in people with insomnia, to see how the brain reacts to this kind of disturbance. And what we found is one difference, and this difference only happened in phasic REM sleep. Phasic REM sleep is the part of the REM sleep where people have eye movements. And we found a reduced amplitude of the P200 wave. And so this is again written here, reduced P2 amplitude in insomnia disorder in phasic REM sleep. This related or was correlated to the discrepancy between objective and subjective experience of how long people slept. And we interpreted this reduced PT amplitude as a kind of mismatch negativity. That is to say, there is an orienting response taking place. Though these stimuli are played like 10,000 times, they are still having, or this orienting response is not blocked as much in insomnia as it is in good sleepers. So we would say that probably sensory channels are more open in insomnia during the whole night than they are in good sleepers. And maybe to end this up, we also did some meta-analysis, and Masoud, you also have published extensively in that area. And here we just did a summary in 2015 about imaging studies. And we came to the conclusion that probably in insomnia, a corticolimbic overactivity interferes with sleep promoting structures. The brain is not sleeping as homogeneously in insomnia as it does sleep in good sleepers. And again, here a summary of the hyperarousal. We think that the data from fast frequencies and the microarousals indicate here an overactivity, or this reflects an overactivity of certain brain areas. We have increased heart rate and we have increased cortisol output. That has also been shown in a meta-analysis. And if we take a very simple approach towards sleep-wake regulation, we would think that sleeping and waking is regulated by an activating system and a sleep-generating system. And if we break this down to the flip-flop switch model of Cliff Saper, we would speculate that could it be that this flip-flop switch is much more unstable during sleep. This would be a good sleeper. The sleep-promoting areas really block the wake-promoting areas. The aurixinergic system is silent. And this is maybe not the case in insomnia. And this is also reflected or mirrored in what the people report, what they experience cognitively during the whole night. Let's switch back to mental disorders. I started out with the data from the 70s and the 80s, where everybody was keen on finding a biological marker. We replicated a few years ago a meta-analysis on sleep in PSG sleep in different mental health conditions. And the interesting thing is here is the REM sleep phenomenon. You see, this is something which is still happening more often in depression, in major depression, but it's also happening. It's also happening in borderline personality. It's also happening in schizophrenia. So this is not specific. And the interesting thing is, and that reflects a change of paradigm, that on the other hand, the disturbance of sleep continuity, which will be prolonged sleep onset latency, increased nocturnal awakeness, early morning awakening taken together, this is something which happens in almost all mental disorders. There is one exception here, seasonal affective disorders, and in ADHD it's not so clear, but it happens in all the other mental health dysfunctions or mental illnesses. So the change of paradigm would say 50 years ago we were looking for specific markers. Nowadays we think that especially the insomnia may be very interesting because it's a transdiagnostic marker for almost all mental health conditions. That is to say, understanding insomnia may not just help us to understand depression, but it may help us to understand mental illness in general. And we speculated about, could insomnia be a gateway to psychopathology? Is this something, if you have a vulnerability for insomnia, you have stressful life conditions, you become chronic insomniac, and with the chronicity, more other more severe mental health conditions develop, like depression or anxiety disorders. And this can also be put into a more biological context. This is something we published just this year together with Laura Palagini. And here again, we have like the Spielman model, the acute insomnia, the behavioral level, perpetuating factors. And there is a vulnerability that the arousal promoting systems overactivate, don't downregulate. The flip-flop switch system gets unstable, and this may have to do also with the orexinergic system. One could speculate about an overactivity of the orexinergic wake system in insomnia, especially also during the night. And this could in the end also lead to, well, emotional dysregulation in the sense of emotional hyperreactivity. And naturally, interestingly, we will have to see whether in the future, whether the new orexin receptor antagonists, whether there are better sleeping medications than the classical sleep medications like the benzodiazepines whatsoever. Now let's talk about what does this mean for clinical practice. First of all, and that has been shown not only by us, by many others, and this is a second meta-analysis we published, insomnia, and these are all epidemiological studies, longitudinal studies investigating insomnia, but psychopathology in general. And very clear it is, if you have insomnia at a given point in time, it increases your risk for becoming depressed later on by a factor of 2.8, and it increases your risk for developing an anxiety disorder by a factor of 3.2. So initially, I started out with saying insomnia is a symptom of mental illness conditions. It can also be the other way around. This is a bi-directional relationship between insomnia and at least depression and anxiety. So not only can you have insomnia as a symptom of these two conditions, but also the insomnia per se can lead to depression or anxiety. And these studies had the measurement points were spaced apart for not just weeks or months, they were spaced apart for years or even decades. And so the interesting question would be, could the treatment of insomnia be a preventive strategy for mental disorders, especially depression? Actually, here I said still needs to be proven, but we have made huge advances. This is a first study trying to having a look at this. And in this study, 1,200 people took part in a study. They all had insomnia and subclinical depression, and they took part in digital cognitive behavioral therapy. And this is depressive symptomatology. This decreased also over half a year later. A control condition did not have this effect. And we have just recently, just a few months ago, this article, an overview, does insomnia treatment prevent depression? And here, you don't need to read it, I apologize, this is just a weak contrast. 6 studies have been published in the meantime showing that you can decrease depression incidence in people with insomnia by giving them adequate, appropriate therapy, mostly with cognitive behavioral therapy for insomnia in that case. Though there is now quite a strong story saying insomnia treatment is not just treatment of insomnia, reduction of the suffering of people with insomnia, but it may also stabilize or strengthen your mental health. Now, a few words about guidelines. There have been several guidelines about insomnia in the last years. The American College of Physicians, the ASM, the German Sleep Society, the European Sleep Society, and we recently published an update here in 2023, diagnosis and treatment of insomnia based on the evidence base. Here are a few words about the diagnostic management. I'm not going through in detail through this, but the important thing is it's not enough one question: do you sleep well? Do you sleep well? Do you sleep bad? You have to have a closer look at this, and especially you have to look for comorbidities, either in the mental arena or also in the somatic arena. That's very important. Insomnia is not just something, psycho or just a stress phenomenon. It can be related to many factors. And so that's important. And if we look at the treatment, we came to the conclusion insomnia disorder should be actively treated whenever it presents. In the presence of comorbidities, clinical judgment should decide whether insomnia or the comorbid condition are treated first or whether both are treated at the same time. So that's up to the clinician. And we suggested that cognitive behavioral therapy should be first-line treatment because it has most of the evidence. There's now a huge amount of studies out there, and regardless of comorbidities. So you can also do this kind of behavioral therapy, cognitive behavioral therapy, in people who are depressed, in people who have a pain condition, in people who have cancer and insomnia. The insomnia will react to cognitive behavioral therapy. We also said that this type of therapy may be delivered either in person or digitally. And we think that especially sleep restriction and stimulus control are the most active ingredients. Now, this is just to give you an overview. What is CBTI? This is a psychological treatment encompassing several strategies, relaxation, imagery, sleep hygiene. Sleep hygiene is a tiny part of this treatment. Many people who are laypersons in the field, they think that sleep hygiene is psychotherapy. Sleep hygiene is not psychotherapy. Sleep hygiene is common sense, don't drink alcohol, don't drink coffee, stuff like that. It's important to mention it, but this is not psychotherapy. Sleep restriction means shortening bedtime. This may sound counterintuitive, but it has been proven to be probably the most important strategy. And we have cognitive techniques. We have even published a book on that together with Chiara and Colin Espy, a kind of textbook which came out last year. And I just like to mention what we really think is very important for clinical practice, that a stepped care model, how do we get this into practice? And we don't only want to have, not just only want to have health professionals deal with that, but we think really that we should talk about sleep, insomnia, mental health. We should talk to pupils in school. We should talk to people at workplaces, at universities, and hospitals. We should develop programs for that. This is not therapy, this is information. And for people on a clinical level having chronic insomnia, the case might be that a first approach would be digital application. If this does not work, maybe group therapy, and if this does not work, a sleep specialist. We have so many people with insomnia, they can't all go to a sleep specialist. General practitioners have to also be able to deal with insomnia. And we think or suggest that this could really have also an impact on the mental health situation in a given country or in a given arena. Properly treating insomnia, avoiding insomnia could really be very helpful in reducing rates of depression and anxiety. So this is my last slide. Actually, these are all the founding sources I had over the last 25 years for my work. And I also like to thank my co-workers in Freiburg, especially Kai Spiegelhalter, with whom I work together now for over 15 years, especially in the insomnia field. And I'd like to thank all of you for listening and for your attention. Thank you very much.